My name is Dr. Thomas Cassidy and I'm an emergency physician at St Charles Gardner Hospital in Perth, Western Australia. Today I'm going to walk you through the basics of emergency rotational thromboelastometry, or ROTEM, interpretation. This is a crucial skill for managing bleeding patients in acute settings. ROTEM is a point of care test that gives us real-time information about a patient's coagulation status. Think of it as watching clot formation before your eyes. The key advantage is that we get results within 10 to 15 minutes, compared to conventional coagulation tests that can take almost hours. Next, we're going to go on to the essential parts of how to interpret a ROTEM. So with emergency ROTEM, we primarily look at three tests. The XTEM, which evaluates the extrinsic pathway, the FibTEM, which looks specifically at the fibrinogen contribution, the INTEM, which evaluates the intrinsic pathway. Now let's look at some stuff that really matters to the emergency physician dealing with acutely bleeding patients. All right, let's focus on what really matters in an emergency. Firstly, the clotting time. This is the time it takes for a clot to start forming. If prolonged in XTEM, think factor deficiency or maybe the patient's on anticoagulants. Normal is 38 to 79 seconds. Secondly is the A5 or amplitude at 5 minutes. This is really important, especially in trauma. Gives you early information about clot strength. Look at it in both XTEM and FibTEM. XTEM A5 less than 35 millimeters suggests you need blood products. FibTEM A5 less than 9 millimeters suggests you need fibrinogen. Next, the maximum lysis. This tells you about clot breakdown. If greater than 15% at 60 minutes, you're dealing with hyperfibrinolysis and you need to give tranexamic acid quickly. In practice, waiting an hour is too long to make the diagnosis of hyperfibrinolysis. Thankfully, there are a couple of early indicators, such as XTEM A5 of less than 35 millimeters or a clotting time of greater than 600 seconds on the FibTEM. Step 1. Check the XTEM clotting time. If prolonged, consider giving clotting factors or if the patient's on anticoagulation. Step number 2. Look at the FibTEM A5. If it's under 9 millimeters, consider giving fibrinogen in any form, whether it be cryoprecipitate or as fibrinogen concentrate. Step 3. Look at the XTEM A5. If that's less than 35 millimeters, consider platelets. Normal, then good clot strength. Finally, step 4, check the maximum lysis. Greater than 15%, consider tranexamic acid. Normal, no fibrinolysis. Let's review some patterns you may encounter in ROTEM interpretation. First is traumatic coagulopathy. The hallmark of this is a reduced A5 in the FibTEM graph. These patients require fibrinogen quickly. Secondly is consumptive coagulopathy. They may have an extended clotting time and reduced A5 in the XTEM and the FibTEM. They may need coagulation factors given. And thirdly is hyperfibrinolysis. They may have a normal graph with a clotting time and A5 in XTEM and FibTEM, but display an increased maximum lysis, and they require tranexamic acid. Now let's go on to our take-home points. Remember, don't wait for all parameters. Start interpreting as soon as the A5 is available. Secondly, the clinical picture is very important. Does the ROTEM fit with what you're seeing in front of you? Third, these are guidelines, not rules. And lastly, if in doubt, consult your local haematologist for any guidance about ROTEM interpretation. That's your emergency ROTEM interpretation in a nutshell. Keep it simple, focus on key parameters, and you'll be able to make quick decisions in critical situations.